you for staying with KTN Prime. We continue the conversation with Dr. Sultani Matende-Chero, who is the Deputy Director General for Health at the Ministry of Health, specifically the State Department of Public Health and Professional Standards. Let's continue with this conversation. I mean, we've talked about donor funding and how it impacts our healthcare service. I've just been texted by one of our viewers, and they want to know, I mean, we also understand that facilities that collect sputum samples for TB testing can't transport them due to this impact that affected the logistic aspect. What are we doing to mitigate this?
Yeah, so you remember when the president, the US president, signed the executive order,
yeah,
he actually put a 90-day period, a freeze to everything for 90 days, during which they would now start reorganizing and realigning the funding to his foreign policy.
Okay.
But at some point, I think because of what we were talking about earlier, you know, there was quite a bit of engagement internally and externally. He changed and said, okay, we are going to give a waiver for some of those services or some of those programs, so that we can now be able to unlock some critical life-saving, you know, programs and activities.
Okay.
So there was a very specific list of, you know, which engagements have received the waiver. And some of them now could be like the logistics, yeah? Which now we are saying, actually that waiver has really come in handy to help us to move. But there are some particular issues which have not received the waiver. So it is now up to us to be able to see how do we come in so that we can now fill in the gaps.
Okay.
Remember, when you look at conservatives, you'll find that, and this is something that probably we have not yet arrived at in this part of the world. When you go to the developed world, you'll find that they have usually conservative wings of politics and progressive wings of politics. And they keep on interchanging.
Yeah.
So you'll find at one point they get tired of the conservative policies and they want some progressive policies. So it helps them to move. So you'll find whereas the Democrats in the US were more open to things like reproductive health, family planning, and so on, the conservatives are saying, no, 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 because they are looking at it in terms of, they work very closely even with some of the religious groups, and they say, no, 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 you should just have morals, we don't want to support things on family planning and so on. So their policies are very different. And in those waivers, you'll be able to see a very clear delineation where they are saying things like now these, you know, the issues around gender, you know, like issues around LGBTQ issues, which were really important to the democratic government. Now they do not want to support those.
Yeah.
So now we have to really look at what is it that is not important to them that we can now pick up, even as we leverage the ones that are important to them.
Okay.
Yeah.
All right. I want us to talk about the fact that you said we need to calm down. Kenyans are upset because they're paying more and receiving less when it comes to healthcare. And just the other day, the Social Health Authority demanded 77 billion shillings in this current financial year that we're going to go to 2025, 2026.
Yeah.
Before we even get to it, let's just listen in to what happened in Parliament.
Okay.
All right, they're trying to get that particular story for our viewers. But one might ask, why do we need more? Yet Kenyans feel like the little that they're given has not been utilized. What happened to the 4 billion? Where is the accountability, transparency?
Yeah, so that's a very good question, very important actually, because one of the things that I really want to just bring out here is that we are in the process of trying to achieve universal health coverage. Yeah? This is not a child's play.
Yeah.
One of the things we really need to do, among many others, is to finance universal health coverage. Now, the former model that we are using under NHIF if we tried to achieve universal health coverage using that kind of funding model, we will not manage.
Okay.
Because it is a very expensive endeavor. So what happens is we have to come up with ways of getting these resources that will enable us to achieve universal health coverage, which is very different from what was happening before. Now, you look at the structure of SHA, the Social Health Authority, because I've also been listening to the conversations. You know, sometimes people say, this shisha is something that people smoke. Yeah?
Yeah.
It is not an authority that will, you know, and I can see that people don't understand.
Yeah.
But SHA, the Social Health Authority, has 3 types of funds. Unlike the National Health Insurance Fund, which was just one fund, yeah, SHA has 3. One is a primary health care fund, yeah. Another one is SHIF, the Social Health Insurance Fund. And then the third one is the Emergency Chronic and Critical Illness Fund, ECCIF.
Yeah.
Okay? Now, the Primary Health Care Fund and the ECCIF, those ones are not based on these monthly or whatever contributions. Those ones are drawn from the exchequer directly. So the government just provides for that. And why do we have a primary healthcare fund? Because we want to now invest in preventive, you know, a preventive approach where we are now focusing on disease prevention, which needs to be funded. We are also focusing on health promotion so that we keep people healthy, we prevent diseases. Now, what do we achieve when we do that? We reduce the number of people who will go to the hospital, who will now need the Social Health Insurance Fund money. We reduce it to a level where it becomes possible for us to now manage this universal health coverage. Remember, for every 1 shilling, yeah, and I want you to get this, for every 1 shilling that we put into health promotion and disease prevention, we save upwards of 9 shillings that would have gone into treatment, rehabilitation, and palliative care. So it is a phenomenal drop in the amount of money that we need to be able to provide curative services in hospitals. That's why the government is investing in the primary healthcare fund.
Okay.
Now, the ECCIF also has a very unique role. Previously, under NHIF, we had things that you hear people talking about, benefit packages. So somebody will come and tell you, I have a headache. And the benefit package looks at it and say, for headache, how much do we need to treat headache? Now, headache can come from very many things. It can be because of an underlying disease, a secondary type of headache. It can be just, you know, primary kind of headache. You cannot really tie it to anything. Maybe it is genetic. Yeah? Maybe it is because you're exhausted, you're anxious, you know, tension headache. So depending on what headache you have, you might actually not even need to take any medication.
Yeah.
But you could even have a headache that will require you to spend hundreds of thousands of shillings or even millions, because maybe it is because of a brain tumor. It is giving you a headache. So if you find that a benefit package, which previously might have been looking at what is the most expensive amount that we need for a headache, you will set a package, you will set a limit at a very high level. So that if somebody comes with a tension headache, they'll ask for hundreds of thousands as compensation. So you find this is a fund which is enriching. It is like something that now opens up to misuse, especially by service providers, for example. So they provide a service that they are supposed to request for 10 shillings, but they request for 100,000, you know?
Yeah.
So to avoid that, we now said, okay, what is the majority, you know? The majority of people, the majority of headaches, what kind are they? They are the ones that maybe just need a certain amount of money. Then we cap it at that. But we say, for those who will need much more, then we now create another fund, which is going to take care of that one. So we have the Emergency Chronic and Critical Illness Fund that is now going to kick in when you find that you have now exhausted. Now you have a critical illness that is not just a normal headache, it's a tumor. It needs 10 million shillings. And we don't want to cap it. We want you to be able to go wherever it is and be treated.
Okay.
Now, there was a bit of a problem that came up because, as I said, this is something that really needs a lot of funding. So you'll find that last year there was an attempt to raise the money that is going to be used to provide these primary health care and the emergency, chronic and critical illness services. But we all know what happened to the finance bill. So we were not able to, the government was not able to raise that money.
Yeah.
But as government, you don't go saying, now that we have not been able to raise money because the finance bill has failed, then we are not going to provide any services. So there has to be some kind of patchwork. And that's why you see there has been an attempt to provide some resources so that services can continue. But that is not how it was expected to be. Now, coming to your question, of course, we get scared of, you know, they usually say once bitten, twice shy. I think we have come from a historical kind of journey where resources are not utilized well and things like that, and we become worried. But you see, that's not a very good thing when you are embarking on an ambitious journey. Because if you reason like that, you will never even leave this room. Because if you go to the road there, you might be hit by a car. But does it mean that you should not go home?
So in your words, do you think SHA is working as it should?
It is taking shape. Because the other thing that we also have to really understand is this cannot work in one day. Yeah, we are moving from an a situation, a model where we were able to just benefit a few people, a small percentage of people, to a model where we want to be able to make sure that everybody is accessing high quality healthcare at an affordable cost. It is a big movement. Now, we were hoping that this transition, of course, it has to have some, it has to be rocky a bit, but we were hoping that it is not going to take very long. Unfortunately, we are spending a lot of time in this rocky part.
So why then roll out a program before testing it?
There have been so many pilots.
So then what's the challenge? Because we cannot say at this particular point it's teething problems. It's been, what, over 5 months?
Yes, I think from where I sit, and this is a very subjective view, is that we have spent a lot of time in the, the storming phase where we are trying to get this, we are trying to move.
Yeah.
If we had that kind of arrangement where I was saying, let's all just come and see what is your role, what is your role, how do we make it work? We have a perfect plan. It's a very good plan for rollout of SHA, for rollout of universal health coverage. So we just look at it and say, okay, so whose role is this one? How do I come in? And everyone has a role to play, by the way. I was telling you in public health, even you are a public health practitioner because of communication. I can come in with a very good intervention, but if I don't communicate it well, a vaccine, and I don't communicate well, nobody will want to take it.
Okay.
So it might take you to come in and communicate it in a way that people will say, okay, yeah, this is okay. So we now identify and say, how do we work together? Because this is a Herculean task. It needs everybody. How do we work to move it together? Unfortunately, now it is me against who is making the mistake, who is doing it badly, and we are stalling, we are not moving. Okay. Yeah?
That's the thing, because look at the Kenyans who are seeking services, systems delays, and all those issues that have been talked about day in, day out for the past, 5 months. Nothing seems to be happening. Just the other week, I think it was last week, MOH admitted that only 3.3 million of the registered 19 million Kenyans are actually contributing, which is another hurdle of its own. So for a Kenyan who is sitting in the house wondering, I cannot access health services, yet the government is insisting on something that clearly is not working. What for?
So those are now the bits and pieces that we really need to bring into context. Yeah? For example, for SHA to work, then we need everybody to be registered. Yeah? Everybody has to register. And it is not the way it was for NHIF to say that me as the head of the household, once I register, now everybody is a beneficiary. We have to make sure that everybody is registered. for SHA to work, and that's why I was a bit disturbed when I saw some of our colleagues saying that they even want to withdraw services.
From Monday,
so
private hospital.
No, I think that is not the way to go. And that's why I'm saying, let's have a conversation. Let's relax, let's talk, let us understand. It will take a bit of time, we might be pinched a little bit, but at the end, we will achieve. All of us are going to achieve what we want. So, for SHA to work, all service providers need to get into contract with SHA, okay? They need to come into a contract. So if you don't have a contract with SHA, somebody will come to your facility and they'll not be able to get services. So everybody has to play their part. So if a mwananchi goes to a hospital and it is not contracted by SHA, they will now come to the media and say, now I have come here, they are telling me this SHA is not working, I have to pay and so on. But it is because the facility has not been contracted.
But the issue of, for example, empanelment, it was a problem on the authorities' side, not the healthcare givers' side. Yeah. Was it sorted?
Of course, it can never start on 100%, you know. And I remember, you talked about the summit that we had on Monday. During that summit, there were even some revisions that were announced, some reviews to what had already started rolling out.
Like?
For example, the amount that is being given for is it chemotherapy or cancer treatment? One of the chronic illnesses, moving from about 4,000 to 28,000. The amounts that are being given, I think, for foreign treatment, moving from 400 to 550,000. So you see that those are reviews that are coming out of lessons learned. Because in the rollout, we have to learn from the experiences. We cannot just start at 100%. But you see, it will not be possible for us to do it if, because of, instead of learning, we are now starting to accuse each other. Yeah? This one, why is it at 4,000? We have to say, okay, 4,000 is not enough. Let's look at the data. Okay, well, how much do we need to increase? Let's increase to 28. So we keep on reviewing as we move.
But
and that's why I was
sorry
saying,
to cut you short, but does the Ministry of Health then look at these issues that are being raised? For example, we just talked about the fact that the private hospitals are wanting to, withdraw their services when it comes to SHA.
Yeah.
I mean, look at what they're demanding. 30 billion NHIF arrears. Last year, the CS of Health was here, and she talked about the fact that 2.5 billion was released to pay these arrears. These are issues that we keep on talking about day in, day out. We seem to not be having concrete, what's the results when it comes to these challenges, or, we're raising as a country, as Kenyans. That's what's causing so much hatred, for lack of a better word.
And anger.
And anger, when it comes to the Social Health Authority.
Yes.
You've seen citizens on TV, I'm sure you follow. These issues that are being raised, are they being addressed? Yeah,
they're being addressed. And that's why I'm saying we need to now just breathe.
It's different if you have a relative who is in hospital, or if you want, to receive health services.
Yeah, so first of all, we need to listen to each other and identify that we have a problem, which we are trying to solve.
Okay.
We are trying to solve a problem by making a universal health coverage available to everyone. It's not, previously, people were having bigger problems, but they were not talking about it because there was no avenue. They were condemned, they knew. In fact, where I come from, I have now started understanding, because I come from a small sub-tribe of Luhya called Tiriki. We are, for those who know Tiriki, we are renowned for even witchcraft. But I have started understanding some of the witchcraft that I used to see as a small boy was actually just illnesses for which we did not have a way of getting treatment. So our explanation was that Jesse has bewitched me, and that's why he has sent a snake to come and bite me, because we could not go to hospital to get anti-snake venom. When somebody is bitten, they die. So our explanation was Jesse has sent a snake because he's annoyed with me to come and bite me, then I die, or maybe the kid has died because bewitched. There were a lot of stories, but now I have started understanding, so this was not witchcraft. This was just bilharzia. It was just a normal disease. So for us now to be able to explain what is happening, we tend to now get it wrong. Yeah? What I'm saying is that let us just calm down. You said 30 billion owed by NHIF. It is a very contentious issue. But there is effort to try and pay that amount. It has been there.
So, for example, this issue starting Monday, what is the Ministry of Health doing to avert this crisis?
Let's talk about this.
Okay.
It has been there for years. How is it that now it is so important that we now have to disrupt everything when attempts are being made to pay? Yes, of course, some money has been issued out. Not all of it has been issued out. Some people have been paid, others have not been paid. So why are we just focusing on the ones who have not yet been paid?
Because it's affecting services.
Yeah. So that's why we also have to look at it both sides. It is not just something that can be done overnight. We really have to be objective. We really have to also be patient. I know it is not the best thing, because even as we do that, lives probably are being lost. People are suffering because of illness. But even if we don't do it, they will continue suffering. So we have to go through this process, work together, so that we can solve this issue. Yeah? So we give it time. You know, by withdrawing services now, how are we helping? It is just going to make things worse, you know?
So what exactly is the Ministry of Health doing right now to avert this crisis?
So, and I really want us to be together on this. You have even said it yourself. As we continue raising resources, we are trying to look at how we can be able to take care of the debt, you know, the debt that we have even carried from NHIF. Remember, for SHA to work, we really need to, the principle is that those who earn more should be able to put in more. Those who earn less should be able to put in less. But everybody should put in a certain proportion of their earnings. Remember, we are talking about earnings, total earnings of the household. However, this is going to enable the ones who earn least to give less than even what they were giving during NHIF. Now, the problem we are seeing is that people are really struggling, you know, like even yourself, struggling to see how do I beat this means testing system so that I give 300. If it were possible, everybody would want to be an indigent so that they don't have to give any money. But let's look at it this way. Personally, I was giving 1,700 to NHIF. Now I am giving about 12,500 every month. What we need to look at it as is not how much more I am giving. It should be how much more am I going to get from the insurance fund. Because if I was giving 1,700 per month and I had to go to hospital and sometimes I have to pay, if this 12,500 is going to enable me to go to hospital and I get the services, then that is a very good thing. Number two, all the time I could see people calling me, sending me texts. Sometimes I just find myself in a WhatsApp group, you know, stand with so-and-so, your auntie, she's supposed to go for treatment in India and so on. So all the time you're in like 5 groups, 6 groups. If this 12,500 is going to enable me to now not have to keep on contributing money, you might actually end up saving.
But it hasn't changed. We're still contributing.
We are in the process. And that's why we need to really shorten this period, work together, understand each other, move together in a way that enables us to move. You know, if you are on a journey and you are just arguing and fighting and you know you have to stop the vehicle first of all and fight.
But Dr. You still haven't answered my question. My question is, yes, what is the Ministry of Health doing to avert this crisis that is supposed to happen from Monday?
No, of course, we are going to engage with our colleagues and other stakeholders who are providing these services and see how we can be able to get to a middle ground.
What about the clinical officers who are on strike?
It's the same thing. You know, we really encourage that instead of going on strike. You know, me, I was even a trade unionist. I was Secretary General of the Doctors Union, yeah, at some point. And one of the things that we keep on saying is, Whereas strikes are very good to the union to be able to enable you to sit with the employer so that you can, when you are not being heard, yeah? In the health sector, we also have to look at it in terms of when we go on strike, what happens? So it is something that we have to look at in terms of, is it really necessary for us to keep on going on strike every 6 months, every 4 months?
So then what is the Ministry of Health doing to avert these strikes? Because it's become an issue year in, year out. It's either doctors after doctors, lab after lab, clinical officers. What are you doing to end it once and for all?
So we have engaged with the unions quite a bit. And sometimes I actually get a bit frustrated because one of the first things I said was that when I was a trade unionist, it was very hard for us to even get audience, to just sit and discuss. But one of the things I said I'm gonna change is we want to give audience to the unions. We have had so many meetings. In fact, when you talk about clinical officers, personally, the union leaders are my friends. I mentored them. And I keep on asking them, why do you want to go on strike? Why can't you come so that we discuss these issues and we solve them without really having to involve the innocent patients? So what we are seeing is that we are really calling out to our colleagues out there. Let us not really be rash to go into strike. Because when we go on strike, people really have a lot of problems.
Okay.
Yeah?
Because we're pressed for time, in 30 seconds, so where are we at as a country when it comes to achieving universal health coverage? Will we meet the set deadline? We
will achieve universal health coverage. It is a very stormy and rocky route, but one of the things that I can tell you is that looking at what we have, of course we are encountering a little bit more difficulties than we anticipated, but we have what it takes. That's why we are there. It is, the plan is very clear. And it is one that when you look at it end to end, it is achievable. We will be able to provide, to deliver universal health coverage for Kenyans so that each and every Kenyan is able to access very high quality standards of health at an affordable cost. It is a constitutional requirement. It is not just an aspiration. If you look at Article 43 of the Kenyan Constitution, it actually makes it a right that every Kenyan has the right to the highest standard of health, and that's what we need to do.
All right, thank you so much for your time and for your nuggets of wisdom. Dr. Sultani Matende-Chero, Deputy Director General for Health at the Ministry of Health, State Department of Public Health and Professional Standards. I am Ashley Mazuri on behalf of Marisha Witi and Jesse Rogers. Have a good night.